Sir, good morning, sir.
Good morning,
Yes, sir.
sir.
Sir, you can go ahead, sir. Sorry for delay.
No problem, sir.
Thank you, sir.
Yes, sir. So, my screen is visible, sir.
Yes, sir. Yes, sir.
Audio quality is good, sir.
Yeah, yes.
So, sir, today is the second talk and the last talk. So, we'll move ahead with the chapter 3. Yesterday, we saw two chapters, the
Yes, sir.
beginning and journey through the temporal bone. The third chapter is the conclusion, that is radiology of the temporal bone pathology. So, what are the most important structures in any ear surgery, sir? Sigmoid sinus, jugular bulb, tegment plate, lateral semicircular canal, facial nerve. These are the most important structure. Always we are worried when you do the any mastectomy procedure. Always this structure can hamper our surgical field if abnormally placed. Also, we have to see for the ossicular chain to decide about the ossicular reconstruction. And the most neglected part, most of the time we don't concentrate at all on the inner ear and the petrous bone. There is a possibility there may be associated inner ear anomalies or involvement of the petrous bone in routine cases of cholesteatoma or even a central perforation cases. So always make a habit. Last but not the least, you have to always check for inner ear whether it is normal or not. Also the petrous bone also, because these two things we never see. We will see the scans laterally and we'll just leave it like that only. We don't much concentrate on the inner ear or petrous bone if it is associated with other pathologies like cholesteatoma is there or some facial nerve tumor is there or any other related pathology. So always concentrate on the inner ear and petrous bone also in the last. So we'll move ahead with the sigmoid sinus. So yesterday we saw how the sigmoid sinus, it is the continuation of the transverse sinus and then it goes and forms the jugular bulb. So yesterday we saw how the sigmoid sinus was looking. Now we see what are the anterior placed sigmoid sinus, how it looks. So first I'll show the pictures and then I'll show you the scans. So look in this particular picture, you can see the sinus where it has come. It is making indentation over the mastoid cortex and it has come inside the mattress cortex, and generally we drill at this level only. So what will happen once you start drilling from this part, you will remove this cortex slowly, and what will happen, you will come to the sigmoid sinus which will hamper your further extension going down. Then what you need to do, you have to shift little your drilling anteriorly and then you have to drill through this passage to reach the antrum. You cannot go from this path because this is the anterior placed sinus. So this is anterior placed sinus. So there is no any proper destination of the anterior or laterally placed sinus. What I generally do, I make straight line from the petrous apex. So this is the petrous apex. From here you make just straight line all along the posterior fossa dura like this roughly. Not that the line should be very straight. So you just make a line along the posterior fossa dura and you see how much part is projecting out. If the significant part of the sigmoid sinus is projecting out, then you can call it as the anteriorly placed sinus, and it is actually visibly also you can say that the sinus is very much anteriorly placed. We'll see another photo. So here you see the sinus, compare with the opposite side. So what I was telling you, draw a rough line from the petrous apex. We'll see the normal side. Anyway, both sides are normal. We'll see the left temporal bone. This is my right side. So this is the left temporal bone. So you just draw a line, straight line all along the posterior fossa dura from the petrous apex and just try to see whether it is projecting out. See here it is very minimally coming out. So this is not an anteriorly placed sinus. You have a lot of place to drill here to reach the antrum. But you see the opposite side. You try to draw a line from the petrous apex all along the posterior fossa dura. Then you will come to know that this much sinus is projecting outside. So this is anteriorly also as well as laterally placed sinus. So this is the very dangerous type of sinus. As soon as you start drilling, you remove the little bit of cortex of 4 and 5 mm, you will immediately encounter the sinus. If you see clinically, here we were trying to do mastectomy in this case, but we saw immediately blue lining here, and we drilled quite anteriorly and superiorly towards the root of zygoma to open the antrum. So this thing you have to keep in mind. Generally, when we do cortical mastectomy, we'll remove the bone from the root of zygoma all along the sinodural angle and up to the mastoid tip. We generally go in the wide cortical mastectomy. But in this particular case, you are seeing yellow bulge, bluish color bulge of the sigmoid sinus. So you cannot drill this part. So in that case, you have to shift little superiorly and anteriorly all along the root of zygoma you have to drill. Here also you have to take care. Luckily in this case, the tegmen was normal. You can see the tegmen is all straight away, both the sides. So this is not low-lying tegmen. If it had have been low-lying tegmen, then it would have been again more difficult to open the antrum in these cases. Then I'll show you particular scan in DICOM, so you can get idea of how it looks in 3D. So what we do to find out the sigmoid sinus? We go in the higher cuts and we find the transverse sinus. It will be somewhere here, and then we keep pressing the sigmoid sinus. Here you can see where the sigmoid sinus is going. What I was telling you, I'll mark it here now. See, this is the normal side. So just try to draw a rough line all along the posterior fossa dura, and see this sinus is not projecting out, means it is inside placed sinus, normally placed sinus. What happened in these cases? You get lot of cortex of mastoid aerosol system to drill around. Opposite here, you see here, you try to draw a rough line all along the posterior fossa dura. You can see it is the anteriorly as well as laterally placed, because see that this mastoid cortex available here. I'll remove this now. See the mastoid cortex, so much, around 7 mm mastoid cortex is available laterally. What is happening here? You hardly got 2 mm mastoid cortex. Once you start drilling this area, immediately you will get the blue lining of the sigmoid sinus. Plus antrum is here, so we drill in this area. This area will be drilling. So you'll get, if you drill here, you'll get the blue lining. If you drill here, you will get blue lining. So again, you have to drill more anteriorly, provided that tegmen should be normal. So tegmen you can see more clear in the coronal cuts. So we'll see in this case if tegmen is normal or not, because all of us know triad of anteriorly placed sinus, prominent jugular bulb, and low-lying tegmen. So here you can see tegmen is quite higher up. So you get lot of space here to go along the root of zygoma and enter inside the antrum. Almost 7 to 8 mm space is there. So even though the sigmoid sinus is anteriorly placed, you can safe-free drill to reach to antrum. Then we'll see another case. So again, same thing. You go in the topmost cut, keep going down. So here will be your transverse sinus. It zoom. So here will be your transverse sinus, and see what is happening at the junction of the transverse sinus and sigmoid sinus. It is already dehiscent. There is no bone in this area. So these are the dangerous cases where you put your periosteal incisions over the mastoid periosteum to expose the mastoid cortex. As soon as you put deep incision here, what will happen? Your blade will cut off this wall of the transverse sinus and the sigmoid sinus junction, and you will get profuse bleeding. So perioperatively, you have to plan when you are putting incision in this particular area. You have to be very meticulous. You cannot put incision bone deep. You have to leave some mastoid periosteum here, and you have to elevate few fibers of the mastoid periosteum, leaving behind some covering over this part. And even if it's getting opened, it is not very big defect. You can just pack it with Surgicel and keep pressure with the thumb, it will stop. Then coming down, again see, try to draw a line from the petrous apex all along the posterior fossa dura. You are seeing this sinus is quite anteriorly placed. Already it was dehiscent at the junction of the transverse sinus. When you are coming down, it is anteriorly placed, and keep noticing where this anteriorly placed sinus is going on. See, it has gone and it has opened even in the posterior canal wall. So the start is only dangerous in this case, because generally we elevate the tympanomeatal flaps. Meatal flaps we take incisions here in the canal. So there only you can puncture this sinus if you don't have preoperative CT scan. So this is the first danger in this case. Second is sinus itself is anteriorly placed, and third one it is exposed in the mastoid periosteum itself. There is no cortex at the confluence with the transverse sinus. So like that you have to be careful regarding sinus. One more scan is there. We'll see what is the state in this scan. So again, go in the topmost cuts. Yes, again same thing you can see here. If I give you time to draw a line all along the posterior fossa dura, you can see the left side, it is not anteriorly placed sinus. You are having lot of cortex of mastoid aerosol system, laterally also and anteriorly also. But here what is happening? Again same thing is happening. See carefully. This is dehiscent again. There is no bone covering here. Again, these are the dangerous cases. If you put your incision with blade here, again it will get open. As well as if you try to draw a line, you can see so much it is anteriorly placed. So like this, visually also and technically also, you should be able to make out that sinus is anteriorly placed in these cases. Because sinus is the most bothersome part whenever we start the drilling in the mastoid cortex. Next comes the brother of sinus, that is jugular bulb, associated with the sigmoid sinus prominence. If sigmoid sinus is prominent, you can expect the jugular bulb will be prominent. Near annulus, the tympanic annulus, it is very, very dangerous part. And next is the distance between jugular bulb and internal auditory meatus you have to see. So first we'll see when it will be associated with the sigmoid sinus prominence. So again, I'll open different scan. Again, same thing, you go in the topmost cuts, find the sigmoid sinus, trace it down. See here, sigmoid sinus is little coming out. Draw a line all along the posterior fossa dura from the petrous apex. This much part is projecting out. Then I'm going down. You can see it is laterally also. Cortex is not much. And then it is almost at the cortex, and you can see then jugular bulb is coming into the picture. So here, see, you are not able to see any bone with over the jugular bulb. So this is completely dehiscent jugular bulb here. It is dehiscent. And when you come up, you can see it is almost reaching up to the round window. Yesterday we saw this is the round window. So it is almost reaching to the round window. So this is high jugular bulb. If you get high jugular bulb one side, immediately we should go and see the opposite side also. Here also same thing is happening. Here you can even appreciate that jugular bulb has already obliterated the round window membrane here. See the round window, you are not able to see that black shadow of round window how you are seeing in this part. This left side, you are not able to see that because round window is completely obliterated with the dehiscent jugular bulb. See this jugular bulb completely dehiscent. Then near the tympanic annulus, if jugular bulb is dehiscent, there is a possibility that it may reach up to the tympanic annulus where we elevate the tympanomeatal flaps from the tympanic annulus. So you have to be careful in that part also. So we want to see the jugular bulb, so we can go even from down to up. So you can see the internal carotid artery, the jugulocaroticoseptrum or crotch. You can see the pars nervosa, the pars venosa, and then when you are coming up, what you are seeing here. See the jugular bulb, laterally it is dehiscent, it is attached to the tympanic annulus and it has crossed over the tympanic annulus when you are going down, and it is lying somewhere in the medial most part of the bony external auditory canal. So this jugular bulb is dehiscent exactly in the inferior part of the tympanic annulus. So what happens when you try to elevate this tympanic annulus from its tympanic sulcus? Uh, there is a possibility that you may pull the wall of this jugular bulb and it will start bleeding. Again, same thing, it looks small dehiscence. Even if it bleeds, you can just put pressure with the Surgicel and with some instrument you can keep pressing over that area for 5 minutes, it will stop. So all these things are surgically very important, like anteriorly placed sinus. Then the jugular bulb, if it is dehiscent, you have to check whether it is in relation with the tympanic annulus or not. Then distance between jugular bulb and internal auditory meatus, you have to see. This is mainly important when you are doing some approaches to the internal auditory meatus, because you require lot of place to drill around the internal auditory meatus. 360-degree all around you have to drill. So this is your internal auditory meatus, and in translabyrinthine approach we drill and remove all this bone. We'll remove the lateral semicircular canal, all the semicircular canal. This we are seeing in the axial. So axial everything looks very good, that we have lot of space, everything. But when you look in coronal, you have to see the distance between internal auditory meatus and jugular bulb, because if jugular bulb is coming from down, see now, this is internal auditory meatus and here is your jugular bulb already has reached. So you get only this much bone to drill inferior to the internal auditory meatus. So this prominent jugular bulb may restrict your access to the internal auditory meatus in the inferior part. Same thing is happening in the opposite side also. This is the right temporal bone. So you can see this is the internal auditory meatus and already jugular bulb is dehiscent here. So when you are drilling from the sagittal part like this, you get hardly any bone between the internal auditory meatus and jugular bulb to drill out. So this limits your access inferior to the internal auditory meatus. Next we'll come to Tegmen plate. So we'll see there is also no any proper definition of low lying Tegmen. So I use similar thing how we saw in the anteriorly placed sinus, how to determine whether it is anteriorly placed sinus or not. So to Tegmen, we know we have to see the coronal cuts. So this is the coronal cut. So again, what I will do, I'll take help of petrous bone. So this is, we know this is the petrous bone. So just draw a line all along the petrous bone. Now you are drawing the line along the middle fossa dura, not the posterior fossa dura. Similarly, you draw a line along this. So if your Tegmen is projecting down the this, you can say it is a low lying Tegmen. Now here in this particular case, what is happening? Both the sides Tegmen is low lying, and you can see this Tegmen is little higher place than this place, than this side, left side. Left side you can say the tegmen is so low lying. So your access to the antrum again will be restricted with this part of the middle fossa, which is projecting down along with the low lying tegmen. So this is roughly, you can say, low lying tegmen. How to identify? Again, draw a line all along the petrous bone roughly and try to see how much part is projecting down. So those two were the low lying tegmen, and we saw in the beginning when I was showing you this scan for sigmoid sinus and jugular bulb. See again this coronal, whether the tegmen is low lying or not. This is one we saw already. So for tegmen, you have to see coronal cut, go up and down. Now see, you have to draw a line along the petrous bone. So draw a line along the petrous bone. You can see hardly it is coming down. So this is normal tegmen, and here also you can make out there are a lot of mastoidal cells to drill below the tegmen plate. So this is the normally placed tegmen here. If it is descending down, it will come down sometime like this. Then you can say this is a low lying tegmen. Next is the most bothersome structure is the lateral semicircular canal. Suddenly we don't know, sometimes it will get uh, in the field, suddenly you will feel that this is the bone which is the lateral semicircular canal. Sometimes even corner septum can mimic like that if it is very thick. If you observe carefully yesterday's scan what I shown you, uh, all the scans were having corner septum. Somebody has written in chat box also. So congratulations, you are correct. That's all the scans almost were having the corner septum. So we'll see the lateral semicircular canal. Yesterday we already saw how lateral semicircular canal looks. So now we'll try to find out what is happening here with the lateral semicircular canal. So again, you go in the top, as semicircular canals are easy to identify from top to bottom. Here is the ampullary end of the superior semicircular canal. I am going down, and here you can see the lateral semicircular canal is coming in the picture. And see the cortex of the lateral semicircular canal is breached. The bone is breached and membranous labyrinth is exposed. So this is the case of lateral semicircular canal fistula. And then when you are reaching this area, you should be approximately knowing how deep is the lateral semicircular canal. So almost 1.5 centimeter you can drill from the mastoid cortex surface to reach the lateral semicircular canal. Now this bone, here it is already automastoid cavity, so nothing to worry. Already cholesteatoma will be covering this part. But if it is a densely sclerotic mastoid, then it becomes difficult to differentiate between the lateral semicircular canal and the rest of the sclerosed mastoid. So in that case, if you have pre-operative scan, you can just simply measure the distance and you can get idea how much you should deeply drill. So we saw already in the axial cut. I'll show you in the coronal cut also how it looks. So both the sides will take so that you can compare better. So this is the lateral semicircular canal of left side. You can see the bone is covering nicely over the lateral semicircular canal. But what is happening in the diseased side? You can see there is no bony covering over this part. So this is blended with this surrounding soft tissue. So this is the fistula of the lateral semicircular canal in the right temporal bone, and left temporal bone it is normal. So when you have one normal and one abnormal side, you can compare easily by seeing both the sides. So see now normal side, how the cortex is intact over the lateral semicircular canal. But in the disease side, you can see the cortex is breached. So membranous labyrinth is exposed. Next is ossicular status. So to do the ossicular reconstruction and to know the status of the stapes or incudostapedial joint in cases of canal wall down procedure, it is very, very important to know the ossicular status. So again, I'll open the scan, the same scan which we already saw just now. So as we know, to find out ossicle, we go from the bottom section to top section. So I'm going from bottom to top now. There is, yeah, you can see now some ossicle is coming into the picture. Just stress it, then you'll get idea what is that ossicle. So it looks like handle of malleus. So this is the handle of malleus, then neck of malleus, and where you are coming up, there is no proper ice cream cone appearance in the epitympanum. You can see both the head of malleus and body of incus are necrosed, and this posterior part looks like the remnant of incus, this posterior part. So you can trace it whether long process is there or not. Again, go down, you can see the long process of incus is there, and even stapes suprastructure is also there. So in these cases, if you are planning to do canal wall down procedure, you have to always disarticulate the incudostapedial joint before removing the bridge. If inadvertently you drill the bridge without removing the remnant incus, that may touch to your suprastructure of stapes and it may push your foot plate inside. So you can see here stapes is nicely seen, anterior crus, posterior crus, foot plate of the stapes, and then this is the lenticular process of incus. So always make a point whenever you are doing the canal wall down procedure in such cases, go in the middle ear first, disarticulate this connection between the remnant incus and stapes head, and then only remove the bridge. Then we do 3D reconstruction also for that. It is called maximum intensity projection or MIP. So MIP will give you all structures separately. Like this you can reconstruct. You can see here now there is a fistula of the lateral semicircular canal and membranous labyrinth is exposed. And here you can see now what we already saw in that axial cut, that the head of malleus and body of incus was necrosed. So we'll compare it with normal side so that you will understand better. So see here, this is the normal lateral semicircular canal of left side. The bone is intact. Here you can see this is the fistula of the lateral semicircular canal. Then coming to the ossicular chain, see malleus head, IM joint, then body of incus, short process of incus, long process of incus, handle of malleus. So nicely you can reconstruct using MIP. And then if you see here, you can clearly make out that head of malleus, body of incus, short process of incus is necrosed. But as I told you, the long process of incus was in connection with stapes suprastructure. So in these cases, first you have to go in middle ear, disarticulate this connection between the remnant incus and stapes suprastructure, and then only you can remove the bridge to avoid any displacement of the stapes suprastructure or foot plate. Then here you can see the stapes very nicely, the anterior crus, the posterior crus, and the head of the stapes. And as I told you, this side also even stapes suprastructure is present. You can see the anterior crus and posterior crus. So like this, using maximum intensity projection, you can reconstruct the ossicular chain. So I saw in chart box, most of the people were asking to again show the facial nerve, and before covering the facial nerve lesions, I will just explain you once again the normal facial nerve. So today I'll explain you little bit different. What I was telling you yesterday repeatedly, how to identify the internal auditory meatus. So this is the posterior fossa dura. It is the right temporal bone first of all. Dissection of the right temporal bone, wet temporal bone. This is the posterior fossa dura. This is the vestibule, and this is the internal auditory meatus. So I told you yesterday, you try to find out extension from the posterior fossa dura towards the otic capsule. So this is nothing but the internal auditory matters. And what I was telling, if you want to access internal auditory matters in toto, like this here, almost it is drilled by Professor Vijendra. You can see he has drilled almost 360 degrees. So if you want to get so much access, this jugular bulb should not come in your way. Now you can see jugular bulb here is very quite lower down. What will happen if jugular bulb is highly placed? Suppose jugular bulb is coming here only. It restricts your access to the internal auditory matters. That I wanted to tell you in the high jugular bulb. Because if jugular bulb is coming from this lower part high up, it's difficult to drill in this part all around. So this is the internal auditory matters. We all know internal auditory matters has 5 nerves, 4 major and 1 smaller. So posterior superiorly will be the superior vestibular nerve, anterior superiorly will be the facial nerve, anterior inferiorly will be the cochlear nerve, posterior inferiorly will be the inferior vestibular nerve, and offshoot from the inferior vestibular nerve is nothing but the singular nerve. Then we know from internal auditory matters, the facial nerve will take C type of turn. So labyrinthine segment is nothing but something C you will see. C type of turn, and then suddenly it will take a acute V turn to form the first genu of the facial nerve. Then there will be dilation in the facial nerve, which is nothing but the geniculate ganglion. Then distally it will be forming the horizontal segment of the facial nerve, exactly posterolateral to the pyramid. This is pyramid, stapedius tendon, head of the stapes, anterior crus, posterior crus. So exactly posterolateral to the pyramid will be the second genu, from where facial nerve will again take vertical turn to form the vertical segment of the facial nerve. So this much anatomy if you know, it's easy to identify facial nerve in the CT temporal bone. So same thing we'll see here now. See, this is the projection from the posterior fossa dura towards the otic capsule. Go and find in your scan projection from posterior fossa dura towards the otic capsule. So this is nothing but the internal auditory matters. Then you go down, you will get the C shape of labyrinthine segment. Same C you can see in the HRCT temporal bone. So this is the internal auditory matters, and this C segment is nothing but the labyrinthine segment of the facial nerve. Then you further come down, you will get bulge in the facial nerve. Bulge in the facial nerve is nothing but the geniculate ganglion. So you can see here bulge in the facial nerve. It is geniculate ganglion. Still come further down. This is the horizontal segment of the facial nerve. This is the horizontal segment of the facial nerve. Still come further down, posterolateral to the pyramid. So this is pyramid. Posterolateral to pyramid will be second genu, where facial nerve is become vertical. So yesterday we saw this image W, where this medial part is sinus tympani, lateral part is facial recess, center is pyramid, and this is posterolateral to pyramid. So this part is nothing but the second genu of the facial nerve. Then you still further come down, you will get the vertical segment of the facial nerve, like this, vertical segment of the facial nerve. If you see in the coronal cuts, vertical segment will be looking like this. And you can see here, this is the level of the stylomastoid foramen. So just few millimeters before the stylomastoid foramen. To speak exactly, is the 2 millimeter before the exit of facial nerve from stylomastoid foramen. You will get the chorda tympani. Here you can see the exit of chorda tympani nicely. So I'll show you the normal scan. So this is the repeat of normal anatomy and radiology of the facial nerve, because many have asked in the chat box to show it once again. Yes, so we'll go in the topmost part. What we are going to find, we have to find the internal auditory matters. How to find it? You have to find the projection from this posterior fossa dura towards the otic capsule. So keep going down, down, down. You got projection from the posterior fossa dura towards the otic capsule. Then this is the internal auditory matters. You got your C shape labyrinthine segment of the facial nerve. Then come down, you got the first turn of the facial nerve, that is the first genu. Then come down, you got dilation in the facial nerve. This is nothing but the geniculate ganglion. Then you still further come down. This is the horizontal segment of the facial nerve. Then trace the distal end of the horizontal segment. You reach to the pyramid. So this is pyramid. Again, W shape recesses, and then posterolateral to pyramid is the facial nerve. Once you get the second genu, just keep it tracing down. So this whole thing is nothing but facial nerve. So you can see here nicely we can make out facial nerve. Why means this bone is densely sclerosed bone here in the lower part particularly. So there are hardly any hair cells to confuse us with the facial nerve. That's why this is the only one soft tissue structure which is continuing till down in the stylomastoid foramen. So this is how you can trace the facial nerve. And if you want to trace it from bottom to top, again same thing, go and find the styloid process. So we'll find the styloid process. Yeah, this is the styloid process. Then trace the styloid process till its base. So this is the styloid process. And where is its base? It is merging here. So this is nothing but the stylomastoid foramen. Once you get the stylomastoid foramen, you can keep tracing it up till you reach to the pyramid. So this is pyramid. So this is second genu. You go still higher up. Then you got the horizontal segment. Now see the diameter of the horizontal segment. And now if you come up, you will see there is a small bulge in this diameter. So this is nothing but the geniculate ganglion. Come higher up, you will get the acute V-turn, that is the first genu, and then ultimately this C-shaped labyrinthine segment which will enter into the internal auditory meatus. So like this you can trace the facial nerve. So facial nerve we know most of the time, even surgically also we see in 30% of the cases the horizontal segment of the facial nerve will be dehiscent either laterally or from medially. Medially side means from just besides the crura of the stapes. That place it can be dehiscent or it can be dehiscent even laterally also. We see come across almost in the 30% cases of our routine ear surgeries. Then other parts of facial nerve which can get involved in other types of pathologies like post-traumatic facial nerve palsy, we know around the geniculate ganglion and labyrinthine segment are the parts which get involved along with the GSPN. Cholesteatoma can involve any part. Keratosis, mostly it is seen to be involving the vertical segment more, but it also can involve any part. And facial nerve schwannomas and tumors of the facial nerve. So we'll see the post-traumatic facial nerve palsy, which is the area of interest in case of post-traumatic facial nerve palsy. So this is the otoendoscopy picture of post-RTA case. So here you can see the eardrum is retracted. There is some fluid collection inside the ear, middle ear. Then you can see the handle of malleus. You can see the head of malleus. You can see there is a small fracture line between the neck and handle of the malleus. And where is the incus? Incus is not at place. Incus is displaced in this case. Okay, so head and handle, there is a fracture between the neck and handle of the malleus and incus is displaced. So this finding you are knowing even on otoendoscopy. Now you have to go and find in your CT scan whether it is correlating or not. That's how you learn to read the HRCT temporal bone. So now we'll open the scan and we'll try to find out whether our CT scan is also showing same thing or not. So to find the incus, what I will do, I'll go directly in the epitympanum to find out the ice cream cone. So here you can see the ice cream cone is not forming here. The ice cream is somewhere and cone is somewhere. Why? Because already endoscopically we know that it is displaced from each other. There is gap between IM joint, head is at its place, but body of incus is pushed laterally, so that ice cream cone is not forming here. And then this is the case of post-traumatic facial nerve palsy. So most of the time in the longitudinal fractures, the area of involvement is perigeniculate area. So perigeniculate area is comprised of geniculate ganglion, Then the first genu of the facial nerve, labyrinthine segment and GSPN. This all area whole combinedly we call it as perigeniculate area. So what we need to do, again we are interested in seeing the facial nerve pathology in this particular scan because it is the case of post-traumatic facial nerve palsy. This patient had grade 6 facial nerve palsy and it was not recovered even after 1.5 months. So we got the scan done and we try to find the labyrinthine segment. So this is the internal auditory meatus. Then you can see the labyrinthine segment of the facial nerve. And as soon as the labyrinthine segment is exiting, you are not able to see the first genu or GSPN very clearly. You can see multiple small this bony density shadows are sitting over that area. So this is the area where in post-traumatic facial nerve palsy, the facial nerve will get affected. Then you go down, see again the geniculate ganglion is not much clear. Again there is some soft tissue density sitting over that area. So this can be some bony spicules embedded in the organized hematoma. Because of the injury there will be bleeding in this area and these bony spicules will get impinged over the exposed part of the facial nerve. See here also you cannot see which is the proximal horizontal segment. Once you come distally only, you are able to make out that this is the distal horizontal segment of the facial nerve. Then you come down, and then this is the second genu of the facial nerve. And once you reach to the vertical segment, what you are seeing, again there is another fracture line which is coming from the sinus plate and it is going over the vertical segment of the facial nerve. Then you still keep coming down, what you are seeing, there is a third fracture line which is coming from the outer part of the mastoid cortex. Again it is affecting the vertical segment of the facial nerve. So the facial nerve is affected in the perigeniculate area, then it is affected in the proximal vertical segment, and then it is affected in the distal vertical segment. So many fracture lines in a single scan you can see here. So this is how you can see in post-traumatic facial nerve palsy. Next is Cholesteatoma or keratosis obturans. So this is the case of keratosis obturans. You can see otoendoscopically, hardly you can make out any landmarks here. It is a complete single otomastoid cavity and filled with cholesteatoma. See, there are no any landmarks to identify whether it is really any ear otoendoscopy or something else. Nothing you can identify apart from some granular meningitis over the tympanic membrane. Rest everything is eaten out and all the landmarks are destroyed by this keratosis and it has become otomastoid cavity and keratosis has occupied everything in that cavity. So in such an extensive disease, you can expect extensive soft tissue lesion involving the temporal bone. So see, this is the temporal bone which we are interested in seeing now. Just I'll scroll scan, keep seeing entirely occupied by soft tissue density lesion. Entirely occupied. There is hardly any space in entire lateral temporal bone which this disease has left. Actually, there is no any space at all. It has eaten out everything, whatever has come in its way. So you can see here how to trace facial nerve in this now. Go and find the internal auditory meatus. You got the internal auditory meatus, labyrinthine segment. First genu, GSPN will go anteriorly and just keep watch on this first genu. Then you can see the geniculate ganglion, the horizontal segment, nothing you can make out because everything is occupied with this soft tissue density. So we could trace the facial nerve till the just beginning of the geniculate ganglion when we try to trace it from top to bottom. Second way, you can trace it from bottom to top. See till when you are able to trace the facial nerve. So we'll go down, we'll find out the styloid process. So this is the styloid process. Come at its base. So this is the base. So this is the stylomastoid foramen. This is the stylomastoid foramen. Come up. So vertical segment looks okay. But what is happening again? The vertical segment, the proximal vertical segment is also exposed to this soft tissue density. So with the scan, we could make out that facial nerve is intact till the beginning of the jelly-filled ganglion, and then from the mid vertical segment down. Rest everything is exposed to this soft tissue density. So unless you open this case and you really see, you cannot make out whether it is just a compressed facial nerve with the disease or it is eroded facial nerve with the disease. So like this, the keratosis can occupy the entire temporal bone. Here you can see the lateral semicircular canal fistula also. There is a dehiscences in the posterior fossa dura and over the sigmoid sinuses also. Even the anterior canal wall also. You can see the anterior canal wall also. There are some micro dehiscences are there. Next is schwannoma. Schwannoma, all of us know the MRI with gadolinium contrast is mandatory for schwannoma. You can see this is the right temporal bone. It's the right ear. You can see this is the anterior canal wall bulge is there small. You can trace out the annulus here. No malleus, no incus. You can see smooth globular mass occupying almost upper 3/4 of the tympanic membrane, and it is going more anteriorly, and even in the superior part you can see some white bulge. So while appearance it looks like some tumor only, if it had been too much white, then we would have suspected the congenital cholesteatoma also. But looking at the appearance, the pinkish smooth globular mass, it has to be some tumor related to the facial nerve, because patient has presented with the facial nerve palsy. So when you get scan done in this case, so we'll see the right temporal bone. We'll try to trace the facial nerve. Why I am directly suspecting the facial nerve tumor in this case? Because clinically it looks like smooth globular mass and patient has presented with the grade 6 facial nerve palsy. So I am suspecting in terms of facial nerve schwannoma only. So again same thing, go and find the interauditory matters. Here is the interauditory matters. You can see the labyrinthine segment, and after labyrinthine segment you are not able to identify anything in the facial nerve because this is a all over single mass here. So once you lost your facial nerve, go down in the scan to find the stylomastoid foramen. So this is the styloid base. Come up, and then this is the stylomastoid foramen. Once you go to the stylomastoid foramen, trace it up. Now see here what is happening. Even this is also dilating. At the stylomastoid foramen it was okay, but when you are coming in the mid vertical segment and proximal, it is again dilating. So this is classical of facial nerve schwannoma, where there will be multiple places will be facial nerve will be affected, also called as skip lesions. So it may be affected in the parotid also even. So in the contrast scan, when you get MRI done, you have to be careful about the parotid lesions also, because facial nerve schwannomas are known to give skip lesions. Sometimes some segment will be normal, again you will get the it is called dumbbell shape appearance also. Sometimes you will get multiple swellings all along the course of the facial nerve. So here in this particular scan, we came to know that labyrinthine segment is normal, and then the distal vertical segment till stylomastoid foramen it is normal. Rest everything in between is dilated. So if you want to see is the same thing in the coronal, go to coronal and identify the stylomastoid foramen. So this is the stylomastoid foramen. See the distal vertical segment, can roughly say from here to here, looks okay. But what has happened to the proximal vertical segment? It is too much dilated. You can see it is dilated. Everything is dilated. So this is also dilated. Till you reach to the interauditory matters, it is one single mass. So how to confirm whether it is facial nerve schwannoma or not? Simple thing, do MRI with contrast, gadolinium contrast. We all know schwannomas are intensely enhancing lesion. So you give gadolinium contrast and check what it is showing. If it is enhancing, surely it has to be facial or schwannoma only. Yeah, see here, you can see, can compare the intensity of the sigmoid sinus with this mass. It is almost same. So it is intensely enhancing lesion on T1 weighted gadolinium contrast. So it has to be schwannoma only. Suppose if it is not taking up the contrast, then what you will do? You will get the non-echoplanar DWI imaging to see whether it can be cholesteatoma. But clinically also it was not looking cholesteatoma. So it goes more in favor of the facial nerve schwannomas. So schwannomas are intensely enhancing lesion, but there is a possibility that if schwannoma is very big, you can get some areas like this. See this area, it is hypointense area. These are the cystic lesions between the schwannoma. So you may get some cystic lesions between this schwannoma if schwannoma is very big in size. So this was moderate size, that's why. And then you trace it, you can see here this, the first part which we saw in the HRCT temporal bone. Open that HRCT again. So you can correlate with your, see, this was the first part which came to the picture. You can see here, same shape, almost same shape. Then you go down, then it has become very big. Go down here also, see, it has become very big. Then go down again, go down. Here also it is there in the vertical segment. So here already you are seeing the vertical segment. So this is the vertical segment. This is the vertical segment, and once you go down, see, it has reduced in the diameter again. Suddenly it has become very small. So maybe somewhat at this level is our scan. Okay. Why I am so much sure our scan is at this level? You see, exactly, it is looking all same. What you are seeing in CT scan, it is there in MRI. You see the sigmoid sinus, jugular bulb, internal carotid artery. See the sigmoid sinus, jugular bulb, internal carotid artery. So this is exactly at the same place where is our scan is. You can even see the mandible here. See here mandible also. So it is correlating with each other. So this is the distal vertical segment which is not taking up contrast, means it is normal. Once you come up, you are seeing there is intensely enhancing lesion in the vertical segment. Same thing, you come up, you are seeing dilation in the vertical segment of the facial nerve. So like this, you can correlate your CT scan with MRI, and surely it has to be facial nerve schwannoma only, because it is highly intensive in the T1 with gadolinium contrast. Next is petrous bone congenital cholesteatoma. So I told you, never miss petrous bone whenever you have got some CT scan. Now I'll show you how it changes your approach to the case. This is the case of congenital cholesteatoma. See now the autoendoscopy picture. Patient presented. If you don't know the history, you may think it is just limited to the middle ear. But history was profound hearing loss since many years and grade 6 palsy since many years. So you can see here the white mass behind the intact tympanic membrane. And this is white mass. This is not that smooth globular mass what we saw in the schwannoma. So this is the white mass, and patient has lost the hearing and grade 6 facial nerve palsy. While looking at it, looks so nice, small mass in the middle ear only. So we may think that it is a limited middle ear congenital cholesteatoma. But with the history, you know, patient is having profound hearing loss and the grade 6 facial nerve palsy. Along with that, patient has a reduced lacrimation also. So automatically you should think that this may be coming from the petrous bone itself. That's why he has lost the hearing as well as the facial nerve functioning. So once you know your history, then you can go and check in your scan whether it is correlating or not. So first we'll try to see what was seen in the middle ear. So to see the middle ear, you come down from up. and see, you are seeing in the middle ear, this much mass only was seen. Now it looks very limited to the middle ear, but when you go and through all the temporal bone, you can make out that this lesion has entirely made mess in the temporal bone. Everything has become mess. You cannot identify a single structure here. If you go by your anatomy, see here again, superior petrosal sinus is nicely seen in this scan. So actually even superior petrosal sinus is also exposed to this soft tissue density. Go down, go down. This is some demarcation of the internal auditory matters, but this is has eroded that area in the internal auditory matters, as well as it has entered into the petrous apex also. So this is the petrous bone. It is entirely going anterior to the internal auditory matters also, and cochlea is completely gone. There is a cochlea, you can see the middle turn, apical turn, basal turn, everything is gone. And there is disease inside the basal turn of cochlea, even inside the vestibule. And facial nerve, you are not able to make out at all from where to start and from where to end. And if you see, even the horizontal petrous carotid is also dehiscent here. So you don't know where the facial nerve is involved in this case. So what is best to do? You go and find the distal end from where you can trace the facial nerve. So go down in the scan, styloid process, styloid brace. So somewhere you will get the stylomastoid foramen. So come up. Yeah, so this is the stylomastoid foramen. Looks normal. Come up. Still looks normal. The vertical segment looks normal. Normal. This is also normal. Looks normal. And now this is the pyramid. This is the facial nerve, and this is some facial recess cell actually. So you come up the horizontal segment, distal horizontal segment, then part of the proximal horizontal segment, and then you are not able to identify the facial nerve. So right from the internal auditory meatus till proximal horizontal segment, facial nerve is involved in this lesion. So this information gives you idea about what you are going to do with the facial nerve. Suppose facial nerve is just compressed with the disease, which is unlikely now because it is so much erosion are there, but still there is a possibility it may be just compressed. So if you decompress it, that is well and enough. But if facial nerve is completely eroded with the disease, you have to think of where you are going to get your proximal segment to do grafting. You have to go till the level of the internal auditory matters to get the proximal segment of the facial nerve. It is almost the porous of the internal auditory matters. So there are chances of CSF leak here, and you may need to graft directly from porous till the second zone of the facial nerve in this particular case. So much information we get from the CT scan. Next is anomalies. So if any anomalies are there, especially of the facial nerve, which can come in your way when you do particularly stapes surgeries, because stapes surgery, everything depends on the status of the facial nerve. The facial nerve should allow you to do your stapes surgery. So we'll go and find the facial nerve. So I'll put both sides so that you can make out better. Yes, so go in the topmost part, find out the internal auditory matters bilaterally. Bilateral anomaly. Okay, you'll see one side only, because opposite side also anomaly. You cannot compare. So go and find the internal auditory matters. So this is the internal auditory matters. Internal auditory matters. Labyrinthine segment. Then the facial nerve is taking turn. But then when you start tracing the facial nerve, generally it goes all along the horizontal semicircular canal, this lateral semicircular canal. But here you can see it is taking turn towards the vestibule. So it is coming medially, and it is coming medially, and it is running over the promontory. This is promontory round window. You can see by this time facial nerve would have gone somewhere this area towards second genome, but still this facial nerve is over the promontory only. You can see this soft tissue, it has covered the round window also, and it is more medially placed. So this is the anomalous facial nerve, where instead of coursing laterally along the lateral semicircular canal, it has taken medial turn towards the vestibule, and it is running over the promontory, and it has covered the round window also. So in these cases you have to be careful, and it looks decent also. So you have to judge whether you can go ahead with the stapes surgery in these cases or not. Sometimes it will be exactly sitting over the foot plate. So in that case, it's not possible, especially for the new beginners, to do stapes surgery successfully in these cases. So you have to be careful about the facial nerve anomaly also. Next, I told you this is mandatory to see the inner ear when you are operating any case of for any pathology. So I'll show you this scan. This was the case of adhesive otitis media, right side, with profound hearing loss. So profound hearing loss itself is giving clue that there is maybe some congenital anomaly in this case. So even if that history would have not been there, you should always look for inner ear. What is the status of inner ear in any scan? Once you see the pathology in the particular scan, you write down the positive findings in the scan. In the end, make habit to look for the inner ear. So we'll see the otic capsule. So here you can see from the beginning only it is look like some different. This is not the superior semicircular canal, it's just a single chamber. We call it as otocyst. You can see it is a dilated vestibule with the hypoplastic lateral semicircular canal. Okay, and some communication, abnormal communication from the internal auditory meatus again. Even you can see the internal auditory meatus is not of normal caliber, it is very small. Then you go down, there is no cochlea. Here we expect cochlea generally. You can see no cochlea. Generally this part we get cochlea. So cochlea is absent, and maybe cochlear nerve is also absent. That's why the internal auditory meatus is very small. Plus there is dilated vestibule with hypoplastic lateral semicircular canal. And what is this case? This case is of adhesive otitis media. So patient came because he is not able to hear, and when we saw endoscopically, it was just adhesive otitis media. So we thought we'll get the scan done, and anyway it was a profound hearing loss. It was the case of adhesive otitis media with cholesteatoma. We have to make ear safe, but we cannot guarantee, or we should not guarantee actually. There is no possibility of hearing in this case because the entire cochlea is absent in this case. There is no cochlea. You can see if I put both the sides, be able to appreciate better. So I'll go down. See cochlea, the normal side cochlea, so nice. Here there is no any cochlea present. Cochlea is absent. Then you come up the dilated vestibule with hypoplastic lateral semicircular canal. This is the normal semicircular canal, and this is the jugular bulb, prominent jugular bulb, but it is not touching to round window, and even cortex is intact. And anyway, this is not a disease site. Disease site was this EDM with cholesteatoma. So primary pathology was adhesive otitis media with cholesteatoma. That is the point what I wanted to tell you. In each and every scan, make a habit to see the inner ear structures, because there can be associated inner ear anomalies. So pathologies of temporal bone, there may be repeat in between because I covered something in the facial nerve also. So pathologies like cholesteatoma, post-traumatic we already saw, otosclerosis we'll see. Paragangliomas and skull-base osteomyelitis we'll see. Only thing I'll skip the post-traumatic facial nerve palsy because we already seen it. So cholesteatoma, what we see in the cholesteatoma, we see the extent of the disease, because depending on the extent of the disease, you are going to decide which procedure you are going to do. Then you have to see if any vital structures are exposed. The vital structures we saw in the beginning are the sigmoid sinus, Tegmen plate, lateral semicircular canal, facial nerve, cochlea. The vital structures you have to see, and you have to see the ossicular status. I'll open one scan. Yeah, this scan we have already seen when I shown you the lateral semicircular canal fistula. So we'll see the extent of the disease. So to look for extent, just scroll this scan from bottom to top. The towards tip it is sclerosmastoid. Yeah, it is sclerosmastoid. And when you are coming up, you are seeing it is the automastoid cavity. So the disease is limited in the upper half of the mastoid air cell system, you can say. As it is sclerotic mastoid, disease has not got much place to expand. Then you saw the extent, it is starting from the supralabyrinthine area, and then it is making the automastoid cavity, and then somewhere in the middle part of the mastoid air system, the disease has stopped because it is the sclerosmastoid down. So you can say the upper half of the mastoid air cell system is involved. Then next you'll see the lateral semicircular canal. It is fistulized there. Then you'll see the facial nerve. Labyrinthine segment is seen. Rest everything is exposed to this surrounding soft tissue density unless it reaches to the second genu. So this is the vital structure which is exposed. That is the horizontal segment of the facial nerve, first genu of the facial nerve, GSPN. Labyrinthine segment is intact. Another vital structure exposed is the lateral semicircular canal. Then next thing you have to see whether sinus is anteriorly placed or not. Visually it doesn't look like anteriorly placed. You can just draw a line all along to see very minimally anteriorly placed, but you have to take care on this area. There is some bone dehiscent in this area. So sigmoid sinus is okay. Laterally cortex, sufficient cortex is there. Next you have to see the Tegmen plate. So see what has happened in the Tegmen. So Tegmen is bothersome here. Almost 1 centimeter defect is there in the Tegmen. So once you get this type of defect, better to get your MRI done, coronal cuts T2, to see whether it is brain herniation or what. But other places Tegmen is thinned out, so it is less likely to be brain herniation. Still you can confirm it with the MRI T2 weighted coronal cuts. In coronal cuts you can see brain part is descending down, you can make out brain clearly. Then again lateral semicircular canal fistula you can see. Next is ossicular status. So we'll see what is happening with the ossicles. So I'm not able to see head of malleus, body of incus. Some remnant ossicles are there. Maybe some body of incus is there and partly head of malleus. And this scan I shown you in the beginning, how the 3D recon will look. That head of malleus and body of incus, short process of incus is eaten out by this disease. And clinically this disease is cholesteatoma. So if clinically you know that disease is cholesteatoma, there is no need to get a non-echoplanar DWI imaging MRI unnecessarily to prove it as cholesteatoma, because clinically you are already proving that it is cholesteatoma. When you are not able to see clinically what that disease is, then you have to get DWI MRI imaging to prove that it is cholesteatoma or not. So I'll show you an example here. So endoscopically, this guy was not having any visible lesion in the middle ear. So now endoscopy picture, try to see from coronal cut. We'll imagine that we are seeing endoscopically. Yes. So generally what happens endoscopically, we'll be putting endoscope from here or our otoscope from here. We can see up to this level. If sputum is intact, you cannot see beyond the sputum. So your access will be restricted. Only this much box you will be able to see through endoscope or autoendoscope. If sputum is intact. If sputum is eroded, then you can see beyond the sputum. So only this box, if you are seeing from the endoscope, what you will think? Handle of malleus is normal, tympanic membrane is normal, middle ear looks normal. Then where is the problem? Patient has presented with the attacks of facial nerve palsy. So facial nerve is somewhere involved. So it can be Bell's palsy also, it can be congenital cholesteatoma also, it can be facial nerve schwannoma also. So how to differentiate? Get the contrast scan done and non-echoplanar diffusion imaging weighted done. Because why to do that scan in this particular case? Because clinically you are not able to judge what it is. Suppose if I have seen the white mass in the middle ear, I'll say it is congenital cholesteatoma. Suppose I have seen the smooth globular bulge here, I would have said that it is the facial nerve schwannoma. But clinically, you are not able to assess which pathology it can be. So in that case, you have to get HRCT temporal bone plus MRI temporal bone with contrast with non-echoplanar diffusion weighted imaging. So we'll see what was the result of diffusion weighted imaging. So this is a diffusion weighted imaging. So what you need to find diffusion weighted imaging, you need to find bright focus, bright like this. You can see here CSF, like this bright focus you have to find in this stage. If it is a bright focus, means it is restricting the diffusion, and that is the characteristic of cholesteatoma. So we'll find out if anything. See here, you can see bright signal here, which is restricting to the diffusion. That's why it is looking bright. So on non-echoplanar DWI imaging, we came to the conclusion that this soft tissue is nothing but the cholesteatoma. So once we know it is cholesteatoma, again go back to our HRCT temporal bone to see where it has affected. So again from top to bottom we'll find the internal auditory matters. We got the internal auditory matters, labyrinthine segment, and you see there is a mass sitting over the first genu and geniculate ganglion of the facial nerve. You can trace it up also. It has gone into the middle fossa dura also. And then down when you are coming, the horizontal segment of the facial nerve is normal. And again, if you go down, see the place which we generally see through the autoendoscope or otoscope, that place looks absolutely normal. There is no any disease in this part. So facial nerve is affected immediately after exit from the internal auditory matters. That is immediately after the labyrinthine segment. But clinically, you could not judge what this disease is. That's why we got the non-echoplanar diffusion weighted imaging, which shown focus of, I'll make it coronal. So this is the area where the facial nerve is affected. We don't know what that disease is, as we cannot see clinically there. So we'll see what the diffusion is showing. So this is the area, same area you can see in the diffusion weighted imaging. The same area is giving bright signal in diffusion weighted imaging here, this area. So this is nothing but the cholesteatoma, and as the tympanic membrane was absolutely normal and intact, it has to be congenital cholesteatoma arising from the supralabyrinthine part. So that is the importance of DWI imaging. It has to be used only when clinically you don't know what is the disease is. If you know clinically or by contrast scan, like in that case, still if I would have doubt, the case of facial nerve schwannoma, I have given contrast already. I know it is the contrast enhancing lesion, so it has to be facial nerve schwannoma. If you have doubt, then you have to get DWI imaging. Post-traumatic facial nerve palsy, I already shown you where you have to trace the fracture line. Then you have to make out involved segment of the facial nerve. If any vital structures are involved and status of the ossicular chain you have to see. So this scan you have already seen. What I'll show you transverse fracture. So currently radiologists, they don't divide it as a longitudinal and transverse fracture. They divide it as a otic capsule involving and otic capsule sparing fracture, because there can be multiple fractures. So here already you are seeing there is a fracture line, the squamous part of temporal bone. This is the fracture line in the squamous part of temporal bone. You are going down, again the fracture line in the squamous part of temporal bone. See, and what is happening? There is a transverse fracture which has involved the superior semicircular canal, the vestibule, the posterior semicircular canal, and vestibule also.
ఇంకా రావాలా మొత్తం
Hello.
గ్రీన్ అయిపోద్ది కంప్లీట్ గా
Sriharsha, I think someone's mic is on. Hello, Sriharsha.
Sorry, somebody cut.
Just mute them, na? So this is, you can see there are multiple fractures. It's difficult to categorize it as a longitudinal fracture or transverse fracture. That's why they always divide it now in otic capsule involving and otic capsule sparing fracture. See, multiple level inner ear is involved. So this is the example of transverse fracture. The fracture line is gone like transverse to the petrous bone, and it is gone throughout the bone. See, till down level it is also there, and when it has gone up to the level of jugular bulb. So next is otosclerosis. So it's a very important to know the normal anatomy and normal radiology to find out the otosclerotic focus, because otosclerotic focus we know they are very small, 1 mm, 2 mm like that. So how to look for otosclerotic focus? So generally we get most of the time fenestral otosclerosis. So you should know where to find the fistula antifenestrum. So we'll open our normal scan. And go and find out the stapes. So we are going to find out stapes. Yeah, so stapes is there. So you can see the stapes, the thickness of foot plate is more, and you can see the area of hypodensity here. This is demineralization focus at the fistula antifenestrum. So like this, you have to see carefully anterior to the anterior crus. So this is the area of hypodensity or area of demineralization, which is a feature of otospongiosis. So all of us know actually otosclerosis is a misnomer. It should be called otospongiosis because this is the spongy bone, demineralized bone. So you can see the focus here. Why I know this? This is the focus here. I'll come to that slides. That time I'll show you once again how the normal looks, and the abnormal. Now only I'll show better. 1 minute. So see the normal foot plate, thin gray color, and this triangle. See, it is the dense triangle here. So this is the normal foot plate with the no any focus of demineralization anterior to anterior crus, that is fistula antifenestrum. What is happening here? You can see the foot plate itself is a thick, it is white structure. Plus there is a focus of demineralization anterior to the foot plate. So this is nothing but the otosclerosis, or more properly called otospongiosis. So this is the focus of otospongiosis. We'll come back to our scan. Same thing you can make out here, the focus of otospongiosis here. Next is you have to see whether there is any involvement of cochlea or semicircular canal, because these patients, they are known to be having associated sensory neural hearing loss, and sometimes even after surgery they will develop fast progressive sensory neural hearing loss. So you have to look for whether cochlea is involved or not. So again, same thing, go to the scan, find the foot plate. So here is the foot plate, and you can see the peripheral demineralization of the cochlea. Complete cochlea is demineralized. So this is nothing but the cochlear otosclerosis. You can see, you already know how the normal cochlea was looking. I'll just check once whether it is unilateral or bilateral. The bilateral. So you can see the cochlea, the peripherally it is completely demineralized, involving all the turns of cochlea. So it is involving all the turns of cochlea, peripheral demineralization of the cochlea, as well as when you come up, you can see even the demineralization of the lateral semicircular canal also. So these are not very good cases for stepidotomy. I'm very not very good cases. You can attempt, but always with the guarded prognosis. Next, you have to see the status of foot plate. Sometimes there is an entity called infraradiological otosclerosis. Means only foot plate will be thick, but there will not be any definite otosclerotic focus. That is happens in some cases. Or even if foot plate thickness is normal and there is no any otosclerotic focus and there is no any other ossicular fixation, if your clinical diagnosis is otosclerosis, radiologically it is called infraradiological otosclerosis. Means otosclerotic focus or fixation is so low that it could not be picked up with the HRCT temporal bone. So here already otosclerotic focus is there. There is no doubt that this is a case of otosclerosis. If you want to measure thickness of the foot plate, you can measure. So see here, generally up to 0.6 mm foot plate thickness is normal. Anything more than 0.6 mm, you have to label it as thick foot plate. So here it is already almost 0.9 mm. So it is a thick foot plate. Opposite side, I'll see if it is normal. This side also. This side of foot plate is even more thicker, almost more than 1.5 mm. So like this, you have to see the thickness of the foot plate also. Then the facial nerve position and dehiscence, you have to see there should be some place between the foot plate and the facial nerve horizontal segment, so that you can do your stepidotomy procedure easily. So this scan we already saw where facial nerve was, instead of moving laterally, it was coming and lying over the vestibule and running over the promontory. So here you can see the interauditory meatus, the labyrinthine segment, the first genu, and see the facial nerve is migrating medially towards the vestibule. So this facial nerve is running over the vestibule. And then it becomes difficult to do surgery in this such cases. Only experienced surgeons should attempt. Let it open completely. And on the opposite side, you can see the facial nerve from the labyrinthine segment is coming out. Labyrinthine segment, and then you can see it is again moving towards the vestibule even more medially than the opposite side. And see what is happening. It is sitting exactly in the over the foot plate, and then it is coming down over the promontory. This is the promontory and this is the facial nerve. Facial nerve generally we go posterolateral to pyramid. Here you can see the pyramid. So by this time, facial nerve would have been in this area, but it is still sitting over the promontory only. So if you still further go down, it is covering the round window. So this is anomalous facial nerve. Bilaterally, more anomalous on the left side. Next, you have to see the associated ossicular anomalies. If ossicular anomalies are there, then that is the case of congenital ossicular anomaly and not the otosclerosis. So we'll see this. What is the ossicular anomaly here? So normal ossicles, we know how it looks. So I'll show you MIP directly if possible. Yeah, see, totally deformed ossicles. No any anatomical landmark apart from the long handle of malleus. You cannot make out which is the head of malleus. You cannot make out which is the incus. And you cannot even make out the stapes. Opposite side also will see. See again same thing. Only handle of malleus you can reconstruct. You cannot reconstruct the head of malleus, body of incus because both are dysplastic. And even the stapes is, this stapes is called as monopodal stapes. So instead of two crura, it will have single crus. So this is called monopodal stapes. It is one of the characteristic of congenital ossicular anomalies. We'll see in axial scan also one side what we can make out. So we'll try to identify malleus. So malleus is coming in picture. This is tip of malleus, handle of malleus, neck of malleus, and see the total ossicular deformation. There is no any ice cream cone. It's just some dilated structures are there, dysplastic structures are there. And when you come down, it is not connection with the monopodal stapes. This side also you can see single crus of stapes with the foot plate. This foot plate also looks little thicker. You just see how much is the thickness of the foot plate. Yeah, it is little thicker foot plate because till 0.6 it is normal. This is 0.7. Then next you have to see internal auditory meatus diverticulum. It is called as concurrent finding. In some cases you may get it is without the otosclerosis, but there is a possibility of presence of internal auditory meatus diverticulum in cases of otosclerosis. It is said that if internal auditory meatus diverticulum is present in the cases of otosclerosis, these cases are more prone to get sensory neural hearing loss development. So what is internal auditory meatus diverticulum? I'll just show you. So as the name suggests, it has to come from the internal auditory meatus. So again, the same principle, we have to go and find the internal auditory meatus. And internal auditory meatus diverticulum will be in the anterior inferior part of the internal auditory meatus. So I think I can take only one side. So we'll go in the topmost cut. This is the internal auditory meatus. We know this is the superior part of the internal auditory meatus. So we have to look around the anterior wall of the internal auditory meatus when we go in the inferior cut. So I am going inferiorly. This is basal turn of cochlea. Here one projection is coming out. So this is nothing but the internal auditory meatus diverticulum, or it is also called as fourth turn of cochlea sometimes, because we know cochlea has 3 turns and this looks like 4th turn of cochlea. So this is the internal auditory meatus diverticulum. It is said that if patient is having this, there is a possibility of development of more of sensory neural hearing loss according to the literature. And you can see this is a very thick otosclerotic focus here. Cochlea is normal, but the internal auditory meatus diverticulum is present. So I'll show you how the other cases it was not there. We'll open focus of otosclerosis scan again. And ocular otosclerosis. There. Just see this scan. Put one side. We'll go at the level of the internal auditory matters. So this is the internal auditory matters, and you see anteriorly it's completely intact. There is no any diverticulum, though it is a case of otosclerosis. So means it need not be present in all cases of otosclerosis. It can be present in some cases of otosclerosis in this area, how we saw in that scan. We'll see in another scan how it looks. Go and find the internal auditory matters. Keep looking at the anterior-inferior part of the internal auditory matters. This is basal turn of cochlea, and again you are seeing the diverticulum from the internal auditory matters in the anterior-inferior part of the internal auditory matters. So this is also case of IAM diverticulum. Then this I shown you, the normal foot plate will be grayish and up to 0.6 mm diameter it is normal. There is no focus of demineralization on this triangle of fistula antifenestrum. While in cases of otosclerosis, you can make out foot plate may be thick and there is a focus of demineralization anterior to the anterior crus. Here you can see step is nicely anterior crus and the posterior crus. Then involvement of cochlea, I told you, the normal cochlea will be dense like this, and this is entirely demineralized cochlea. So this is the cochlear otosclerosis. Then semicircular canal normally looks like this. Here is the involvement of the lateral semicircular canal by the focus of demineralization. Then status of foot plate. The foot plate will be normally thin and gray. The foot plate will be considerably white and it will be thick. You can measure the thickness. Then facial nerve positioning, I told you it moves away along with the lateral semicircular canal from the vestibule. Here in this case, what has happened? Instead of moving along the lateral semicircular canal away from the vestibule, it has crossed the vestibule and it has come inferiorly. Later it will go and cover the round window. So next is paragangliomas. So we all know it has divided into tympanomastoid and tympanojugular paragangliomas. You have to see extent of the paraganglioma. You have to look for the involvement of the facial nerve. You have to see whether lower cranial nerve involvement is there or not. Then you have to check for intracranial or extracranial involvement whenever you get the paraganglioma scan. First, you need to decide whether it is tympanomastoid or tympanojugular. Second, see the extent. Third, see the facial nerve. Then see the lower cranial nerve and see then whether it is extracranial or intracranial. So investigations of choice are contrast enhanced CT scan and MRI with gadolinium contrast. So we'll see the scan of tympanomastoid paraganglioma first. So tympanomastoid paraganglioma will be limited in the middle ear. So clinically, you will see picture like this. The sunrise, typical sunrise sign in the inferior part, typical sunrise sign of the paraganglioma. To label it as tympanomastoid or tympanojugular, the imaging is mandatory. Clinically you can judge, but still on the imaging you can confirm. So we'll see first the normal scan, left side. So we'll see where is the soft tissue extension. So you can see the soft tissue mass sitting over the promontory. This is the basal turn of cochlea, and it is going and occupying the mouth of the eustachian tube orifice also. So it is a smooth mass, looks limited to middle ear, and in this particular case you can see there is a thick bone between the jugular bulb and this mass. Internal carotid canal is also intact. So it is a limited from the hypotympanum and little anteriorly towards the eustachian tube. Then you give contrast. We'll see the contrast enhanced scan what it is showing. So I'll come up. So you can see this mass is taking up contrast. Why? Because if you compare the contrast subject of the sigmoid sinus, this mass and the internal carotid canal, all is same. So this is intensely enhancing mass. Come up, you can see till the eustachian tube orifice opening, that mass is there. So clinically, it was confirmed that it was paraganglioma because it was pulsatile, red-looking, anterior-looking mass giving rise to sunrise appearance. And radiologically, you have confirmed that it is the tympanomastoid paraganglioma. It is nowhere in connection with the jugular bulb, because jugular bulb is quite down here and very thick bone is there all around the jugular bulb. The mass is quite far away from the jugular bulb. So this is the tympanomastoid paraganglioma. So next we'll see the tympanojugular. So we'll see the CT scan first. Right side region. So we'll come to middle ear first, find out the mass. Yeah. So this is the mass in the middle ear. You are seeing it is sitting over the promontory. Then you have to see the extent of the mass. First go up and see whether it is extended somewhere in the mastoid air cell system or not. It is not gone to epitympanum nowhere. Then you trace it down. So we can trace it down now. See that mass is still continuing and it is actually increasing in the size, and you can see there is a typical moth-eaten appearance of the jugular foramen. Also, the jugulo-carrascopic septum is eaten away. So this is the moth-eaten appearance of the jugular foramen. Second will be some, you will not see these areas of whitish moth-eaten appearance. You will see just the jugulo-carrascopic septum will be eroded. That is called Phelps sign. So this is the moth-eaten appearance of the jugular foramen. It is characteristic feature of the jugulo, tympanojugular paraganglioma. So once you know that it is involving the jugular foramen, you can confirm it with either CT with contrast or best is MRI with gadolinium contrast. So you can actually see the even feeder vessels also. Let the scan load. Scan is very big, that's why it is taking time to load. So you can see salt and pepper appearance in the jugular foramen. You can see flow voids of the feeding vessels. So this is intensely enhancing mass. You can see the flow void even in the sigmoid sinus also. So whenever you see the salt and pepper appearance in the jugular foramen, it is diagnostic of the jugular foramen paraganglioma. That is tympanojugular paraganglioma. You can see the opposite side, there is not much contrast uptake. There is just flow wide of the internal carotid artery and the internal jugular vein. But this side you can see there are a lot of contrast uptake in the jugular foramen area. And last, I'll take osteomyelitis culpes. So for osteomyelitis culpes, you can get contrast enhanced CT scan done or MRI with gadolinium contrast or nuclear scan like technetium 99 scintigraphy, you can get it done. So yesterday I was telling you, even with the plain scan, you can identify actually if the infratemporal fossa extension is there or not in cases of skull base osteomyelitis. I'll open first normal. CT scan. So see this particular scan, it is a without contrast scan. What I was telling you yesterday is to identify the planes, this soft tissue planes, this is fat planes, it is called as. So you can see, you can compare the both the sides of infratemporal fossa in this. You can see lot of fat planes are there in the right side, but left side it is all totally obliterated. This is the case of left side osteomyelitis skull base. You can see lot of bony erosions are there all along the skull base as well as extension into the infratemporal fossa. So just on seeing this plane scan, you can tell that this side the fat planes are obliterated. Why fat planes are obliterated? Because swelling in the muscles. muscles have got swollen up because of inflammation, and these fat planes are lost in this case. And if you see in the soft tissue window, I think soft tissue window is not there. Okay. And make it more prominent, you can see lot of grayish areas. The fat planes are present in the right side but obliterated in the left side. So in skull base osteomyelitis, you have to concentrate on this area. Even in the plane scan, with the plane scan also you can make out that it is obliterated. And if you do MRI with contrast in these cases, show you with MRI with, you can make out the severity of the osteomyelitis skull base, that how severe it can be. You can see the enhancement on HRCT temporal bone. It has enhancing so much region that it has crossed over to the opposite side. So it is the right osteomyelitis skull base. You name the structure in the skull base, it has involved in this case, and it has also crossed over to the normal side also. So much extensive can be the skull base osteomyelitis. How to identify on plain HRCT temporal bone? Try to find out the fat planes, whether it is intact or not. So I tried to cover maximum topics. You know, all this single topic can take almost 2 hours to explain in detail, but I tried my best. If you have any queries, you can ask now, or else later you can send me on WhatsApp or on my email ID. So Sriharsha, any questions are there?
Hi, Nilesh.
Yes, sir.
Yeah, this is Vishnuvardhan from Hyderabad.
Yes, sir. Tell me, sir.
It's an excellent presentation. I compliment for this. Yeah.
Thank you, sir.
Regarding the skull base osteomyelitis, when
Yes, sir.
looking at malignant otitis externa,
Yes,
can we tell the patient about the prognosis?
Osteomyelitis skull base, sir. Even if you are
Is
seeing
there any
limited disease, no, sir. Osteomyelitis skull base, because the treatment, everything depends on a patient response to IV antibiotics, sir. So in the first time only, when you come to know that it is the osteomyelitis skull base, though it is limited, looking limited to the external auditory canal, and imaging also showing that, we never know how the patient will progress. So in the beginning only, we always tell them that it is the disease of bone, that is the skull base bone, and as all of us know, that it's difficult to reach there, that area, especially the IV antibiotics, because bone is hardly any having vasculature. So it's difficult for any antibiotic to reach that area. And if it is a patient is a sugar patient where HbA1c is very high, it is uncontrolled diabetes. So already all of us know that antibiotics are also not going to work that much effectively. So in the first visit itself, though we see it is a limited, we always say that it may progress and it may involve the further bones. Even we are treating, there is a possibility that ultimately patient may lost the life also. So in the first visit only, even if we see it is limited, sir, we always explain to the patient, sir, because we cannot predict the progression of the disease. We have seen some cases where even after giving antibiotics for 1 or 2 months also, patient have not recovered, sir. Then afterwards they should not say that doctor has given me antibiotics for 2 months, still I am not recovering. So in the beginning only, you should give them idea that what this is disease is exactly. And second thing also, you have to make them understand, sir, why it is difficult to treat this disease. They should understand that bone is not having much of the vascular supply. That's why for any of the IV antibiotic or oral antibiotic, it is difficult to reach that area to act over that particular bacteria. So that's what how we explain, sir, to our patients.
Like how often do you see the patients are recovering?
Sir, you can say with our protocol where we use IV meropenem 1 gram TID and Ciplox 200 milligram BD for 6 to 8 weeks. You can say if it is a limited disease, the recovery is very good, sir. Almost more than 90% patient will recover. But in the beginning only, if disease is very extensive, sir, involving the parapharyngeal space, nasopharynx, paracarotid space. So in these cases, it becomes difficult. So they also respond, but percentage is very less, sir. You can say 30 or 40% patient, means less than half percent of patient, they will respond.
Thank you, Nilesh.
Yes, sir. Thank you, sir. Oh, this corner septum, 1 minute, Sriharsha. I again forgot to show you today. I actually wanted to show that. Somebody has again mentioned corner septum again. So we'll go back to our scan. See the scan, whatever I was showing, you can see here nicely the corner septum. This is the corner septum. It creates fall impression of entering the antrum. This thick bone will be there. You will mistake this thick bone as the lateral semicircular canal and you will think that you have reached the antrum, but you will not open the antrum actually. You have to judge it with the level of the middle ear. So this is the corner septum. Most of the scans you will be seeing this corner septum, may be complete or incomplete. So that was the corner septum. Here also you can see corner septum. So what happens once you start drilling from here, you will reach to this thin bony plate. It will look thick laterally actually. Then you will take it as a lateral semicircular canal and you will stop your drilling here. And then you will not open the antrum. So this is the corner septum. Yeah, Sriharsha, anything next?
Sir, any more questions, sir?
Yeah, that's what I'm asking.
We are looking for audience.
Yeah.
Ramesh, sir, you can give the closing remarks, sir. Yes.
Yeah, somebody asking for Ramana Husky. Sir.
Foramina of Husky, it should be dehiscent, sir. Then only it will be seen.
Yes.
I will try to incorporate in the next time because I don't think I have any scan where it is dehiscent. Unless it is dehiscent, you cannot tell that it is foramen of Husky.
So thank you so much, sir. It's a wonderful session for our Telangana AI branch.
Thank you very much, sir.
It's a new beginning for our Telangana. And most of the people asking about the YouTube channel, sir. In future we are going to launch YouTube channel. We'll upload all these sessions. I want to encourage all the people, including postgraduates of Telangana all over the country, to watch live sessions. Then after 2 months, we will going to put this in YouTube, sir.
Yeah, sir.
Thank you so much, sir. Once
Yes,
again.
and to learn the HRCT temporal bone, today only itself you download some software, either DICOM or Horos, bring some CD and just try to open it. Once you try to see on your own, you'll feel happy seeing the CT scan. First, even when I was not well versed with HRCT temporal bone, I was so much scared of HRCT temporal bone. I used to run away whenever it will come to HRCT temporal bone in my PG days. Then once I am now seeing the more and more scan, I am becoming confident.
Thank you, Nilesh, for the wonderful message, advice for all of us, brother, more so the residents. Thank you. For underlining the going back to the CDs, going back to the radiology department. That's how we'll learn. Excellent. Thank you so much for underlining those things.
Yes, sir.
Appreciate.
Yes, sir. And today also, after learning so much, I have now 2 o'clock appointment with Ramchandra sir. I need to go to and need to meet him and see any interesting scans he has seen in last 1 month.
Wow.
Nice.
Excellent. Yeah.
So thank you, Nilesh, sir. And
Thank you very much.
our next session will be on coming Saturday, sir. Thank you, sir.
Fine, sir.
Thank you,
Thank you,
Ramesh.
sir. Thank you all. Thank you for joining.
Thank you, Nilesh.
Thank you, sir. Thank you very much, sir.
Yeah. Harsha, you can end the session.